Good morning, my friends. Well, it's actually morning now. I don't know about when you're watching this, but anywho, welcome to Respiratory Lecture number 1 of 3. Actually, I might do it in 4. The second lecture is generally on the longer side, so I might split that up into 2A and 2B, so to speak. But anyway, number 1, we're going to talk about pulmonary ventilation, which is the action of moving air into and out of our lungs. And it's not that hard, but we're going to do it in little chunks. Um, so by the time we're done, this slide would tell you that you will understand the different pressures that are associated with lung function, which that's basically where we're going to start. We're going to talk about the mechanical events that occur to create those pressure differences to move air in and out of the lungs. And then we'll talk about the factors that affect pulmonary ventilation. Now, I'm not going to bother showing you this, but since we're talking about pressure, this is it's kind of a running joke that I always use in classes whenever pressure comes up. But this is a link to a live video that Queen did back in 1981, I think it was, at Wembley Stadium in London, their song Under Pressure. But anyway, I just like it, and so I put that in there for funsies. All right, now on to the important stuff. So pulmonary ventilation. Now, you've probably heard me say at some point in class, I don't know how often I say this in the videos, but chemistry is evil. Chemistry is Satan. It is Voldemort. It is Palpatine. It is whatever you associate with evilness, the dark arts. That is what chemistry is. And so you'll probably hear Boyle's law in chemistry. But where we're concerned in this context, Boyle's law states that at a constant temperature, the pressure of a gas varies inversely with its volume. So, yes, Rogers, chemistry is Satan. I agree with you. What does that have to do with us? Well, my friends, in this current context of when we're talking about moving air into and out of the lungs, uh, and pressure and volume, and you have to think about a container, okay, the volume. So the volume we're dealing with here is the volume inside the thoracic cavity, inside your chest, okay? And whenever we inhale, obviously we increase the volume inside of our chest cavity. And when we do that, the pressure in the chest, called intrapulmonary pressure, the pressure in the lungs, intrapulmonary pressure gets lower. Now, the important thing here is it gets lower than what? Decreases relative to what? And the answer is actually atmospheric pressure, which we'll kind of build on here in just a second. Okay, so again, when we inhale, when we increase the volume of our thoracic cavity, the pressure in the lungs, called intrapulmonary pressure, drops below atmospheric pressure. Now, when we exhale, okay, the volume clearly in our thoracic cavity decreases. Therefore, the intrapulmonary pressure actually increases or gets higher than atmospheric pressure. So, atmospheric pressure, again, we're going to build on this here pretty much right now. Actually, you know what, let me go ahead and get to that, and then we'll kind of work Boyle's law back into it. So there's three pressures that we need to discuss here when we talk about breathing. And I've been mentioning intrapulmonary pressure. Now, this is the one specifically that Boyle's law is referring to, and how it changes in relation to atmospheric pressure. Okay, now atmospheric pressure doesn't change if you're at an altitude of, let's say, if you're at sea level. Atmospheric pressure is one thing. Okay, if you are at 1,000 feet, atmospheric pressure is constant at that altitude. So atmospheric pressure is constant at any given altitude, and that doesn't change when we breathe, but intrapulmonary pressure does. And so this is, again, the pressure that we're referring to when we talk about this relationship here in Boyle's law. So when we inhale, again, our thoracic cavity volume increases, and the intrapulmonary pressure, the pressure inside the chest, drops below atmospheric pressure. When we exhale, the volume decreases and intrapulmonary pressure rises above atmospheric pressure. Now, we're going to get to the importance of that in just a second. All right, so atmospheric pressure. Now, as you're watching this video and as you're studying and you're taking notes, which you should be, And if you're writing questions down, one thing that I typically do not emphasize and usually ever ask people to remember, I don't care about numbers. Okay, so don't worry about 760 millimeters of mercury, or you might see the term atmosphere, like 1 atmosphere. Don't worry about any of that. I don't care about those types of things. All I want you to focus in on is the relationships that make these things happen. Now, the third pressure, so we've got atmospheric pressure, intrapulmonary pressure, and then this one here called intrapleural pressure. And we're going to get to that one in just a second as well, but this is the pressure inside the pleural cavity. Okay, now remember, if you've taken anatomy, the pleural cavity is the space between the visceral pleurae and parietal pleurae. Okay, it's the visceral pleurae is the lining of this double-layered pleurae sac that covers the lung, and then the parietal pleurae lines the chest wall. And the space between them is called the pleural cavity, and there's a pressure that exists there called the intrapleural pressure. And here's the important thing: intrapleural pressure is always, in a normal healthy lung, is always negative to intrapulmonary pressure. Now, whenever intrapulmonary pressure changes with the rise and fall of the chest, this will change correspondingly, but it always remains negative to this. And the reason that that's important is that helps keep the lungs inflated, and we'll get to that a little bit more in just a second. Again, this is always, in a normal healthy lung or lungs, is always negative to this, and that keeps the lungs inflated and functionally useful. Okay, so those are your three pressures that are involved with breathing. Let's see, and this one gets a little bit more into that. Don't worry about transpulmonary pressure. Like it says here, it's just the difference between intrapulmonary and intrapleural pressure. We're not going to discuss that at all. Let's see, okay. Before I go into the specifics of, and a little bit more in depth into the relationships between intrapulmonary pressure and atmospheric pressure and how that actually moves air, let's talk a little bit about intrapleural pressure, how it's established, and again, just reinforce why it's important. So like I said, it's always negative to intrapulmonary pressure, which we abbreviate P subscript PUL. All right, so this is intrapleural pressure and then intrapulmonary pressure here. But again, remember, it's always negative to intrapulmonary pressure. Now, what establishes this negative pressure relationship? All right, now you have the lung tissue. Now, if you were to crack open a chest, okay, and look at the lungs from a frontal view, you wouldn't actually, what you're looking at is elastic tissue that encloses or encompasses or covers up, encases, whatever term you want to use, the alveoli, because the alveoli make up the bulk of the lungs by volume. The lung tissue itself is fairly elastic. And you could imagine that as the lungs fill up with air, the lung tissue stretches. And then when the lungs release air, the lung tissue recoils. And so this elastic nature of the lung tissue that exists is always pulling inward on the chest, because again, whenever we breathe, the lung tissue is stretched. And so this elastic property of lung tissue is always pulling inward, effectively trying to make the lungs collapse. Okay. Now, there's something else that actually kind of adds to that inward pull on what's called the respiratory membrane, which we will get. Let me see. I don't think I get to it here. No, I'll talk about the respiratory membrane, I believe, in part 2. But on the inside of the alveolar walls, there's a thin film of liquid molecules. A thin film. I can't talk this morning. Thin film of fluid. Now, I'm going to try and speak more clearly now for you guys. I apologize for that momentary lapse. I think the hamster in my brain wheel fell off for a second or stumbled. But anyway, okay, so this thin layer of fluid, the fluid molecules are chemically attracted to each other. And when you collectively add the pressure, okay, of the fluid attraction between all the fluid molecules between both lungs, that creates an inward pull. So as these fluid molecules are attracted to each other, they're effectively trying to make the alveoli collapse in on themselves. All right, so you've got this inward pull from this what's called surface tension, and then you've got the inward pull from the elastic property of the lungs. Now, if those two forces weren't opposed, then the lungs would easily collapse. But thankfully, chest wall has an elastic property to it and is always pulling outward on the lungs. And so the inward pull of the lung tissue is opposed by this outward pull of the chest. And then there's something in the lungs. There's a type of cell in the alveolar wall called a type 2 cell, and it secretes this chemical. So let me just kind of add this there. Secreted by type 2 cells. Okay, so this chemical surfactant is secreted by what are called type 2 cells. And what surfactant does is it weakens this surface tension. So it decreases the physical force that this is creating, essentially opposing it, kind of weakening it. So you've got this opposing relationship between the elastic property of the chest wall, the opposing relation, or the inward pull of the lungs themselves, and then you've got the surface tension of alveolar fluid being weakened by surfactant. This interplay between these forces creates this negative pressure. It's like not, I don't want to use the term suction or a draw, but this kind of a pull on the lungs that always keeps them inflated. And remember, this pressure is always negative to intrapulmonary pressure, and that again keeps the lungs inflated. And if anything were to physically compromise the integrity of the pleural cavity, it could weaken or completely do away with this intrapleural pressure. And if this intrapleural pressure, if it equilibrates to atmospheric pressure, then the lung will collapse. So if air gets in the pleural cavity, it's called a pneumothorax. And again, if that disrupts this negative pressure relationship, then what can happen is called an atelectasis, or a collapsed lung. Now, generally, if in some cases it's not necessarily life-threatening, but it could be depending on the nature of the injury. Sometimes it can happen spontaneously, which is the only type that I've ever seen in an ER. But generally speaking, let's say if somebody experienced some sort of physical trauma and this pleural cavity were compromised, they can typically stick a chest tube in it, suck out all the air, and then reestablish this negative pressure relationship. And then ultimately the lung ideally will reinflate and the person will not lose the lung. But again, the importance that we're focusing in on here is what intrapleural pressure is, the fact that it's always negative to intrapulmonary pressure, and then the super important fact of the matter is that as long as that negative pressure relationship exists, then the lung stays inflated. Okay, now let's get to the movement of air. Okay, and let's take these and put these pressure relationships put them to use here. All right, so inspiration or inhalation. So let's just so we're clear on what we're talking about here. Okay, inspiration or inhalation. This is what we would call an active process. Now, active process in this context is not like an active process that we talked about in our membrane transport lecture. Okay, so remember in that lecture, when we were discussing active versus passive processes, we were discussing those types of processes that either needed or didn't need ATP. Now, active in this context means that muscle contractions are actually driving this process. So that's what the active is referring to, muscle contraction. Now, we've got what are called our inspiratory muscles, which are the diaphragm and the external costals. And so you need to remember, if you have to remind yourself and look these things up, where they are. Now, the diaphragm is a flat dome-shaped muscle that is inferior to the thoracic cavity. It essentially separates the thoracic cavity from the abdominal cavity. So you've got the diaphragm, and then you have the external intercostals. Now, when they contract, okay, when they contract. What they do when the diaphragm contracts, it kind of moves inferiorly, okay, adding volume to the thoracic cavity. And when the external intercostals contract, they elevate the rib cage and move the sternum anterior. Now, the combination of those three things, sternum moving anterior, elevating the rib cage, and the diaphragm flattening, that collective work increases the thoracic cavity volume. And remember, according to Boyle's law, if we do that, intrapulmonary pressure decreases. And the important thing is here that you remember is that it decreases relative to what? Okay, it decreases relative to atmospheric pressure. And so whenever when we inhale, these anatomical changes occur, intrapulmonary pressure drops below atmospheric pressure, we have now what we would call a pressure gradient. We've talked about different types of gradients in the past, concentration gradients, and so on, but now we have a pressure gradient. So if intrapulmonary pressure is lower than atmospheric pressure, that's a pressure gradient. So another way to look at it would be atmospheric pressure is higher than intrapulmonary pressure. And here's the thing that you really want to focus in on, you guys. Air, right here, air flows into the lungs down its pressure gradient. That's what I want you to focus on. Okay, so air will always move down a pressure gradient. Air will move from high pressure to low pressure always. That's not my opinion. That is fact. And again, I've given you guys illustrations about fact and opinion. My opinion is the original Star Wars movie is the greatest movie ever made and that ever will be made. That's my opinion. Well, kind of fact, but you know what I mean. Okay, facts generally can't be disputed. Okay, now this is fact. This is not my opinion. You cannot dispute this. You can't disagree with me on this one because it's true. So whenever that happens, whenever we create those anatomical changes, there's a volume change that creates a pressure gradient. Okay, and air will move down the pressure gradient. And so let's kind of put this little puzzle together here, and then you'll kind of see how it works as we go on. So let's summarize it basically. Muscle function, muscle action, whether it's contractions or relaxations. Okay, so muscle action creates volume changes. Those volume changes create pressure gradients, and the pressure gradients are what move air. Okay, so again, muscle actions, whether that's contractions or relaxations, create volume changes in the thoracic cavity, in your chest. Those volume changes will create pressure changes between intrapulmonary pressure and atmospheric pressure. It'll create pressure gradients, and those pressure gradients move air. Very simple, very direct. Okay, so that is how we inhale. All right, so our inspiratory muscles contract, creating anatomical changes that increase the volume of our thoracic cavity, that create a pressure gradient, and air moves from the outside of our body in through the nose or the mouth, or both at the same time, and into the lungs. Okay, now what would we call, okay, I'm going to skip slide number 12 here and we'll go back to it. Now, expiration. Okay, what if we want to, well, I don't like to use the term expiration because if you work in healthcare, expiration means something entirely different than exhaling. Okay, if you don't know what I mean, ask somebody that works in healthcare. Okay, expiration generally means that a person dies. So I like to use exhalation. So when we inhale, which is what we just talked about, okay, it's a passive process. So if inhalation is an active process, meaning our inspiratory muscles contract, exhaling is a passive process. So the diaphragm relaxes, the external intercostals relax, and let's talk about the anatomical changes that take place. When those relax, the diaphragm moves back up, moves superiorly. When the external intercostals relax, the sternum moves posterior, goes back to its resting position, and the rib cage depresses back to its resting position. Now, when that happens, the thoracic cavity volume decreases. And then according to Boyle's law, okay, that would mean the intrapulmonary pressure actually goes up. It gets higher than atmospheric pressure. And now we have a pressure gradient in the opposite direction. So air in the lungs will move out of our body. So remember, muscle function, muscle actions, in this case, muscles relaxing, create anatomical changes that decrease the thoracic cavity volume, which increases intrapulmonary pressure, and now it's higher than atmospheric pressure, and air moves out of the lungs because it moves down that pressure gradient. So I can't stress enough, what we're talking about here is quite simple. Okay, it's all about, if we're talking about moving air, which we are, it's all about muscle function, muscle actions, whether that's contractions or relaxations, creating anatomical changes that now create volume changes. These volume changes create pressure gradients, and pressure gradients drive air movement, whether that's into or out of the lungs. So if you can remember that, you're going to be just fine. Now, that's what we would call quiet respiration. Okay, quiet inhalation, quiet exhalation. Basically just what you're doing, at any given moment, watching TV, sitting in class, sleeping. Okay. But you guys know that sometimes maybe you're exercising, maybe you're sick, maybe you have some sort of respiratory disorder. If you have to move more air, forced, I think, implies something wrong. So let's, add a little context to this. And if we say forced or deep inhalation, okay, forced, again, kind of implying that perhaps there's some sort of respiratory disorder, or maybe, again, you've been doing a spin class and your exercise has been pretty vigorous. Or if you're just taking a deep breath to maybe blow out your birthday candles, or every parent makes the mistake at some point of buying their kids something that needs to be blown up, whether it's floaties or, little tiny swimming pools or whatever. I made that mistake multiple times when my kids were little. But now I'm way past that. Okay, so whatever the context is, if you need to move more air into your body, you've got to take a deep breath, right? So the first thing that has to happen, okay, actually let me add something here, is that the inspiratory muscles need to contract more forcefully. Okay, so that's step one. Okay, so let's change that color there. Let's go green. Okay, so if I want to take a deep breath in, my diaphragm and external intercostals need to contract with more force. But that's not going to be enough to move actually the air that we need in. So we have to create a greater pressure gradient, a steeper pressure gradient. And if we do that, more air will physically move. And so on top of these muscles contracting more forcefully, scalenes and sternocleidomastoid in the neck are going to contract. Pec minor will also contract. It's in the chest. And then the erector spinae group in your back will contract as well to extend the trunk. Now, collectively, when these contract and get in on the action, okay, normally dominated by the diaphragm and external intercostals, they will increase the thoracic cavity volume greater than normal. And so if the volume goes up, okay, the pressure inside will drop more than normal. It'll create a greater pressure gradient. And when we do that, more air will go in. So if you need to blow out all those birthday candles, man, take a deep breath. This is how you do it. You create a greater pressure gradient to get all that air in. Okay. Now you take the air in. Now, if you're going to blow out those birthday candles, what do you got to do? You actually have to exhale, right? So this is also, the quiet exhalation is passive. If we're going to be dealing with this forced or this deep exhale, again, blowing something out, that's an active process, because the first thing that would have to happen, okay, is all of these muscles that we just listed that they contract, so your inspiratory muscles and these guys here, What's the first thing that has to happen if you're going to blow out your birthday candles? It's all of those muscles that we just mentioned have to relax. But that's not going to be enough to create the volume change we need, to create the pressure gradient we need to get that air out and blow out your candles. So what has to happen is that your core abdominal musculature, your internal, external obliques, rectus abdominis, transversus abdominis, those are all going to have to contract as well. And that creates intra-abdominal pressure that's going to be directed upward against the diaphragm. And then the internal intercostals are going to contract, and that's going to depress the rib cage even more. And so when you get that collective work of all of those muscles relaxing, and then these guys getting in on the action and contracting, that's going to drive intrapulmonary pressure higher than normal and go further above atmospheric pressure and drive the air out. Now you can blow out your birthday candles and have that cake that you've been salivating over. Okay? So my friends, that is how we breathe. So here's what let me give you a suggestion. Okay. If I were you and I'm studying this material, I would create a spreadsheet for myself. Okay. And have 4 different columns. And then you can add whatever you want to this, but I would have a column that would have all of the events in different rows that explain normal, quiet inhalation. And then another column, how would I explain quiet exhalation? A third column for deep or forced inhalation, and then a 4th column for deep or forced exhalation. Okay, because they all are a little different. And if you can fill that up, you're going to have a really good understanding of the processes that drive pulmonary ventilation, which again is simply moving air into or out of the lungs. Now, real quick here, let's go in and talk a little bit about some of the factors that affect pulmonary ventilation. Resistance, airway resistance, alveolar surface tension, and lung compliance. Okay, so airway resistance, what are we dealing with here? Okay, airway resistance. You know what? Let's add something here. What is resistance? Okay, so airway resistance, let's just call it, abbreviate here. Airway resistance, AR, is the ease at which flow through our airway. So resistance is the ease at which the air can flow through our airway. So we would, if you want to elaborate on that, okay, if resistance is higher, that means something is making it difficult for air to move through our airway. If resistance is low or normal, it's easy if resistance is normal, it's easy for air to flow through our airway. And if airway resistance gets lower, then of course it will be even easier for air to flow through the airway. So that's what resistance is something, if air is being opposed, if the flow of air is being opposed. Okay? Now, it's normally not that big of a deal. Our airway, especially the upper airway, is fairly large in diameter. And then remember, from anatomy, the deeper you get into the bronchial tree, the airway starts to get smaller and smaller, and smooth muscle starts to dominate the makeup so that the body can actually control the airflow in certain areas. Okay. Now, again, resistance is talking about the opposition to flow. Very similar in nature to when we talked about blood flow in our blood pressure lecture with resistance there. It's kind of the same thing. So if anything is opposing the flow of air, that would increase airway resistance. So let's say that, and so just again, let's talk about some examples of things that would increase resistance. So let's say you have a chest cold, bronchitis, or something like that. And maybe there's some mucus kind of built up in portions of the airway. If there's mucus built up in the airway, that's obstructing the diameter of the airway, making it harder for air to flow. And therefore, we would say that mucus or this condition is increasing resistance. Maybe it's mucus. Maybe it's inflammation of some sort, maybe during asthma. Inflammation generally causes a decrease in resistance. A decrease in diameter, which would mean that a smaller diameter is harder for air to flow through it. So inflammation, mucus, those things are going to increase resistance. A severe allergic reaction, is going to increase resistance. So, like if you have again a severe allergy to something random like a peanuts or shellfish or bee stings, or I recently just I know somebody, and I didn't realize this, but I know somebody that has a severe allergy to tomatoes, of all things, and they have to carry an EpiPen for that, which I thought was pretty crazy. I've never heard of that one before. But here's the point, you guys: if anything shrinks the diameter of the airway, that increases resistance and makes it hard for air to move, therefore harder for us to breathe. So let's flip that and say, what could decrease resistance? What about warm, moist air, like from a humidifier that you might run while you're sick? A medication like Mucinex, some sort of expectorant that helps break up mucus, so that way we can get it out of the body. Okay, some sort of rescue inhaler. Okay, that someone might take for an asthma attack, like albuterol or something like that. When both of my kids were super little, I actually had to take each of them to the ER because they both had asthma as infants, and which we didn't know at the time until, of course, I had to take them to the ER is when we found this out. And then we had an inhaler, or the, oh gosh, I'm brain farting. The oh gosh, whatever it is, the machine that you hook up to run the albuterol. Oh gosh, I'm forgetting. I'm brain farting. I can see the stupid little thing in my head that we use many times. But anyway, when you try and introduce some sort of medication like that, it relaxes the airway to make it easy to breathe. Epinephrine. Okay, if you have a severe allergy and you need an EpiPen, you inject that into the body, and the epinephrine, oh gosh, I'm going to mess this up, binds to beta 2 receptors, I believe it is, in the smooth muscle of the airway, and it causes vasodilation of the bronchioles, increasing their diameter, making it easier for air to flow. All right, so that's what we're talking about here with resistance. Anything that increases resistance makes it hard for air to flow, therefore making it harder to breathe. Anything that decreases airway resistance makes the diameter of the airway increase, air flows much better, and we breathe easier. Now, we've talked about this a little bit already, so I'm gonna skip this. Surfactant. We already talked about surfactant. Now, again, if and this isn't usually much of an issue in adults, but occasionally, remember, maybe you've known somebody, but if infants are born prematurely, sometimes they have to stay in a hospital for an extended period of time because they have trouble breathing on their own. Their body, the type 2 cells in their lungs haven't gotten to a point where they produce enough surfactant naturally, and so it's harder for those little ones to breathe. And so if that's the case, they have to stay, because doctors can give them surfactant synthetically to help their lungs be able to expand and contract, and they can breathe more efficiently. And then hopefully, and I always say hopefully because not everybody is fortunate enough to come home with their little ones healthy. If all goes well, then at some point their body is going to catch up, and the type 2 cells are going to produce enough surfactant on their own to reduce that surface tension and allow the lungs to not collapse, to function normally, and then go home. So that's why oftentimes if you see, again, premature infants staying in the hospital, it's because their lung function isn't up to what it should be. And then last couple things here. Let me see. Oh, yeah, I talked about some of that stuff. Okay, compliance. Okay, lung compliance. Now, we're not talking about complying to laws or some sort of HR nonsense. Lung compliance, okay, is literally referring to the stretchability of the lungs, their ability to expand and contract. Okay, Now, if anything, and under normal conditions, it's not much of an issue. Lungs are capable of expanding and contracting. Air is able to move in and out normally. However, if lung tissue is somehow compromised, if normal, healthy, elastic lung tissue is damaged and replaced by scar tissue does not is not flexible like normal elastic lung tissue is. And if something happens and somebody's lungs are injured and their normal tissue is replaced by scar tissue, then the lungs again will not be as flexible, will not contract and relax as easily. And when that happens, they are not able to move as much air in and out. And that's going to translate into us having a more difficult time to breathe. Okay. So again, now I'm not exactly sure about how those types of conditions are treated because I don't see physiologically how like fibrous scar tissue is actually going to be healed and changed back into normal elastic tissue. So yeah, that's one thing that I've never really looked into, and if it's even possible, I doubt it. But again, hopefully I'm wrong, and I'm not. I don't have an issue admitting that I'm wrong. Okay, now a couple more things here. Why are lung volumes and pulmonary function tests important? Well, let's say you go into a doctor, you're having trouble breathing, and they run pulmonary function tests where they might hook you up to some sort of machine where you're breathing, and they start looking at different types of lung volumes. Well, what they're doing, you guys, is they're assessing lung function. They're looking at how much air you can move into and out of the lungs. And they can take these pulmonary function tests, look at your volumes, prescribe treatments, okay, and then say, all right, let's here's what I see according to the data. I'm going to try this treatment and try and improve your lung function. And then let's say you come back a month or 6 weeks, 8 weeks later, and they redo these pulmonary function tests to see how the treatment worked. And if it worked, great, you're breathing normally again. But if it didn't, then something needs to be changed. Athletes, generally not just your general athletes, but probably your elite Olympic class types of athletes will do pulmonary function tests, on occasion to see how effective different types of training programs are and whether or not they need to be modified. So that's what pulmonary function tests are going to do. They're going to be important for those sorts of things. Now, all of these types of volumes, I typically don't go over much in lecture, but I have them in here because you're going to in your lab, in your PhysioX lab, you're going to be experimenting with these. So I put them here so you can kind of have an idea of what some of the terms are and what they mean that are typically involved with pulmonary function tests. And then the last thing here is, and again, this is not your average sort of topic. Nurses generally don't deal with this. Respiratory therapists might, but something called VO2 max testing. It's mainly used again by athletes, and again, not your run-of-the-mill athletes. We're talking about elite types of athletes here. Generally assessing how efficiently their body is using oxygen during generally intense sorts of anaerobic types of exercises. And so you can click on this link to kind of get an idea of what that might look like. But it's important for athletes to develop and evaluate training programs. Okay, so going back over this real quick, we're just at coming up on 39 minutes here. So remember the most important things in this particular topic. We're talking about pulmonary ventilation. So how do we move air into and out of the lungs? All right, remember it's all about muscles contracting and relaxing. Those actions create anatomical changes that create volume changes in the thoracic cavity. It's either going to go up or down. Those volume changes create pressure gradients between intrapulmonary pressure and atmospheric pressure, and air will move down the pressure gradient, whether that's going to go in or out. When we inhale or exhale, it's all about that sequence. Okay? So keep that in mind, and you're going to be just fine. Take care.